Welcome to today's lesson. Today we are looking at palliative care, and my name is Benjamin Kiri Ampa of St. Carol's School of Nursing. Palliative care is a branch of nursing that deals with pain management of patients who are chronically ill. When I say patients who are chronically ill, patients who have terminal illness, like patients living with cancer, patients living with HIV/AIDS, patients living with end-stage kidney disease, patients living with rheumatoid arthritis, hypertension, diabetes, and the rest of them. So we want to look at how we take care of such patients who are having chronic illness and are in their terminal stage of the disease, and pain has become a daily burden on them. How do we manage pain? How do we blend knowledge with skill to meet their physical, psychological, physiological, social, socioeconomic, and spiritual needs of such people? Palliative care is developing as an area of special clinical competence throughout the world. It is developing because it hasn't transcended to all parts of the world. Even when you take Ghana, Ghana doesn't have a place where nurses are trained specially to take care of patients with palliative needs, such as a hospice, or doctors who have trained purposely for taking care or giving palliative care to patients. As general nurses and medical officers, however, in the course of our training, we are giving some knowledge, and we acquire certain skills in the clinical area, and we are able to take care of people who are chronically ill and also meet their needs. But if you talk of Ghana, we do not have a school that is specially into palliative care, training nurses and doctors in that enterprise. It is the Ghana College of Nurses and Midwives that is trying to bring out some model like that, which it has started freshly. And so palliative care is a developing area in nursing and in Africa and the world at large. The modern hospice is a relatively recent concept that originated and gained momentum in the United Kingdom after the founding of St. Christopher's Hospice in 1967. It was, the palliative care is attributed to have found or have been found by Dame Cicely Saunders, widely regarded as the founder of modern hospice movement. So the founder of palliative care is Dame Cicely Saunders. Palliative medicine have been recognized as a specialty in UK since 1987, in Australia and New Zealand since 1988, and more recently in Canada. So if you take a developed country in Canada, they are even now going into or having their palliative care developed. And so indeed, it's an area of nursing or medicine that is still developing. In July 2006, the first meeting of palliative caregivers towards the formulation of Ghana Palliative Care Association took place at the conference room of a non-governmental organization, Palliative Care. Those present were these people, and they convened this meeting to propagate the development of palliative care in Ghana. Now, the definition of palliative care according to WHO 2018. Palliative care is an approach that improves the quality of life of patients and their families facing problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, including physical, psychological, and spiritual. So palliative care is a quality of life that is given to patients who are facing terminal illness, patients who are facing life-threatening illness. They are the kind of patients that palliative care is meant for. You give them, you identify their problems early, and also you give them quality care, impeccable assessment, and a subsequent quality care, and also treatment of the pain. Because most of them go into severe pain, chronic pain, that even when they take oral analgesics, it doesn't help them. Some of them want to take injections every day as a result of the cancer, as a result of the end-stage kidney disease, as a result of rheumatoid arthritis, as a result of diabetes, HIV/AIDS, multi-organ failure, come with severe pain. And so such patients need specialties or specialists that have undergone training to take care of their needs. And so, I mean, according to WHO, palliative care is an approach of improving the quality of life of patients and their families. It's not only the patient, but together with the family. Because if the family is well informed, they will also provide support to the patient through prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, including physical, psychological, and spiritual needs. Palliative care is also defined as mitigate the suffering of patients, not to effect a cure. And so palliative care do not target cure. It targets improving quality of life and also solving the problems, suffering of the patient. And so if it is cancer, you don't intend to cure a malignancy. You don't intend to cure an end-stage kidney failure. You don't intend to cure a diabetes. You don't intend to cure HIV/AIDS, but rather your target is to eliminate the immediate suffering, the immediate pain, the immediate anguish, the psychological trauma of patient and family, so that their quality of life will be improved. Aims of palliative care: to relieve symptoms and improve quality of living and dying for a person and or family living with a life-threatening illness. So one of the aims of palliative care is to improve the standard of living, the quality of life of the dying patient. So just as Virginia Henderson said, you are giving the patient nursing care so that the patient will die a peaceful death. And so even though the person will die, the person has gotten a terminal illness to the extent that this person cannot be cured of his or her illness, you still have to intervene in the person's problems. You still have to identify the person's problems and intervene accordingly. Not only the patient, but you also need to attend to the needs of the family so that the family would be able to understand and be in the position to support the dying patient. It is also to help individuals and families address physical, psychological, social, and spiritual needs. So this palliative care is also to assist the individual and family to give a holistic care to the patient. You want to assist the individuals with knowledge. You want to assist them to relieve them of any anxiety. You also want to explain the condition to them so that they do not stigmatize and draw close to the patient and give the love and belonging that the patient requires. You also want to ensure that you imbibe in them some fear of God to be able to incur God and also to be able to invite their source of belief into the person's illness, so that together with the physical, psychological, and social, spiritual will also be added to give an all-encompassing care to the patient. To also prepare, manage life closure and dying process. One of the aims of palliative care is also to manage life closure, that is dying. How the person approaches death is the main aim of palliative care. You want to improve life, add quality to life, and not merely adding days to life, but you add quality to life so that even if the person will die peacefully. To support with loss and grief during illness and bereavement, even after the patient has died. Palliative care targets at you giving support to the family that have lost their loved one, also grieve with them, and also give them the necessary support during the illness and then the bereavement. Now let's talk about principles of palliative care. The principles of palliative care include respect, the likes and dislikes, goals, choices of the dying. According to the ethical principles gathering or guiding nursing, one of the ethical principles in nursing is autonomy. And autonomy states that you need to respect the independence of your patient. So one of the general ethical principles in nursing is autonomy, which says that you need to respect your patient and their independence. And so palliative care and the principles gathering it is no different. You also have to be autonomous by respecting. When I say autonomous, it is coming from the word autonomy, which is an ethical principle. Respect the independence of your patient. And so, by means of autonomy, you need to respect the likes and dislikes of your patient or the dying. Integrate of course, how would you respect the likes and dislikes? Especially when you are busy resuscitating a patient, giving a patient oxygen, patient who is dying, suctioning the patient, giving emergency medications to the patient, or to inure to the quality of life you would want to give to the patient. And this dying patient only shout and tell you that, leave me to die, I am tired. In that particular moment, must you respect the lives of the patient? You cannot leave a patient to die, no matter how a patient wishes to die. And so, in as much as you need to respect the likes and dislikes of a patient, you also have to make sure that you do not commit malfeasance, which is causing a harm to the patient, which is also an ethical principle that guides your practice as a nurse. Integrate the physical, psychological, social, and spiritual aspect of patient care. And so, palliative care must be holistic. It must cover all the dimensions of care in nursing by providing the patient with the physical needs, psychological needs, social needs, or socioeconomic needs, spiritual needs. Offer support system to patients to help patients live as actively as possible until death. And so you must make sure you improve the quality of life of the patient as much as you can. Because mostly the patients who leave palliative care are bedridden patients. And these are patients who are confined to bed, developing pressure sores, taking medication all over. Some medications are taking 6 hourly, some 3 hourly, and so almost all the time they are suffering side effects of medication aside the burden of the condition that they already have. And so you must make sure you improve the comfort of the patient in bed. You must make sure ventilation is provided to that patient. Basic needs that the patient needs has to be provided, just as Virginia Henderson states in her theory. You must also make sure you improve ventilation, you improve the patient and his or her immediate environs, just as stated by Florence Nightingale. You also have to make sure that there is a good and serene interpersonal relationship, nurse-patient relationship, as stated by Hildegard Peploe. All of these things must help come together and give the patient good care that will elevate the patient's quality of life from bad to fair or good or even satisfactory or excellent. You do not say that because the condition is incurable, you allow the patient to gnash his or her teeth to death. That is not nursing. Nursing is improving the quality of care of the patient till death, so that even though the patient will die, everything points to the fact that nursing care was given and no compromise was done whatsoever to contribute to the patient's death. Patient-centered rather than disease-focused. In giving care to a patient who is having or who needs palliative care, you must not center the care on the disease, but you must center the care on the patient. So the care you give to the patient must be patient-centered and not disease-focused. What does that mean? You do not just go and stand by the patient and check vital signs, and when there is any abnormality in the vital signs, you intervene accordingly, and then you go and sit your somewhere. You must listen to the plight of the patient. In as much as you have some values called vital signs, you must also listen to the problems of the patient. You must move per the needs of the patient. In as much as certain needs of the patient might be medical and you cannot compromise on that, you must also make sure that you take the patient's concern into consideration. You must make sure that the care is centered around the patient, is centered around the needs of the patient, not the disease necessarily. Because the needs of the patient, when met, you can get the disease resolved. If a patient is taking medication, for example, as a nurse, you have done your duty by administering medication to a patient. Meanwhile, this is a patient who deep down within her, she is troubled. She is fed up with taking medication. She thinks that the medication that she is taking is impotent. The medication is not efficacious enough to meet her disease. She's been taking these medications since, for the past 3 years, and to no avail. And so the patient herself has lost hope in administering the medication. As a nurse, your only concern shouldn't be going to stand by that patient and issuing the medication or administering the medication to that patient. You must make sure you educate the patient. You must make sure you prepare the patient's mind. You must make sure you support the patient in all dimensions, be it physical, psychological, social, spiritual, so that the patient will verbalize her anxiety. The patient will verbalize her worries, her fears, her concern, so that you address them appropriately and add the medication. And so the patient will be taking the medication on a well-prepared mind. Right, so palliative care is also concerned with healing rather than curing, as I've said already. It rather concerns itself with taking care of the suffering of the patient, the immediate suffering of the patient, and not necessarily curing the individual. Affirms life and regards dying as normal, as a part of the life cycle. So palliative care, in just a simple terms, targets improving life, target improving the life of the person who is chronically ill, than focusing on dying, because the dying happening as a result of the condition the person is having is just a normal process. Because this is a person who have had, or who is having a terminal illness, and so dying is a normal process. But palliative care sought to improve the quality of life of such patients. Still on principles of palliative care, provides relief from pain and other distressing symptoms. So palliative care seeks to provide relief from pain, which is the utmost target of palliative care. Relieve pain and other distressing symptoms. Death accepting, but also life enhancing. Palliative care is death accepting, because if death happens as a result of a terminal illness, it is expected and it will be accepted. But palliative care, again, is life enhancing. It enhances the quality of life of the person who is having the chronic illness. Intends neither to hasten nor postpone death. So palliative care neither hasten nor postpone death. It give you care, improve the quality of life, so that death will be or will occur as a natural process. Death will occur as a natural process. It adds life to days and not days to life. What it means is that palliative care focuses on quality of life and not necessarily extending the life of the patient, even when the patient is suffering, even when the patient is in anguish. All that you need or you want is that the patient is lying in bed and in some way, somehow, the patient is breathing. Palliative care sees the patient as an individual who needs tender love and care, and so the palliative care seeks to improve the quality of life, improve the environment, improve the basic nursing care, improve the nurse-patient interaction and relationship, rather than just the nurse going there to give care and then moving away from the patient, even though you are giving nursing care, but there is no proper nurse-patient relationship. There is no comfort in the care you are giving to the patient. There is no human face to the care you are giving to the patient. There is no heavy shoulder for the patient to rely on, so to speak. And so palliative care seeks to improve the quality of life a patient needs, not just improve prolonging days of the patient. And we are sometimes, the patient even doesn't need the prolonging of the days because it is prolonging suffering. Okay? The patient needs the quality of life. The patient needs the pains that he is going through or she's going through resolved, relieved. The patient needs her fears addressed. The patient needs to know certain information about the disease. The patient wants to know how she is going to fare. So the patient needs certain critical information about the condition, and the nurse is available to give to the patient. And that alone gives the patient a sense of relief, and that is palliative care. The palliative care do not only seek to reduce the pain with analgesics, but it also seeks to reduce the pain in the heart of the patient by just a mere word. Just a conversation relieves the pain in the patient's heart. Family support brings socioeconomic needs and support to the patient. Spiritual needs are also met. And then the patient's quality of life improved. Not necessarily walking to the patient, this patient is on chemotherapy, you administer the drug, and then that's it. That will not be adding life to days, but rather you'll be adding days to life. Partnership between patient and care providers. There should be a partnership. There should be a good and humane interaction between the patient and the caregiver. Support the needs of the family members. So that the nurse or the palliative care nurse must be able to support the needs of the family members. Be it psychological needs, if it's education that they need, or if there is something that they need to do for the patient to enhance the patient's quality of life, the nurse must be there to liaise between the patient and the family members. Palliative care for children is the active total care of the child's body, mind, spirit, and also involves giving support to the family. As I said earlier, there are general ethics in nursing, and those ethics too are in palliative care. And these ethics include confidentiality. Confidentiality is that the nurse must keep patient information private. When we say keep patient's information private, what it means is that information that you have read from the patient's folder, from nurse's notes, from all patient's documents must be kept private. You only discuss the information among the medical team, and with that one, it will yield benefit to the patient, not unofficial sources, not unofficial places. You do not share the information when it will not bring any benefit to the patient. So if a patient confides in a nurse to release an information, the nurse must make sure that the information is released in a judicious manner, which will not go to implicate the patient, but rather it will bring benefit to the patient. Confidentiality is also that the nurse should not be releasing information that the patient has released privately to you. Sometimes a patient can call you and by way of confiding in you tells you that I'm a marijuana. I've been smoking marijuana for the past 15 years. Please don't tell anybody, for example. And so if a patient has been smoking marijuana for the past 15 years and a doctor asks the patient whether the patient is on drugs, the patient said no. And for that matter, the doctor has prescribed a certain analgesic or even a certain dose of analgesic. But if the doctor knew that the patient was abusing substance or was on marijuana, such analgesic wouldn't have been prescribed. Maybe a stronger one would have been prescribed just to meet the pain of the patient. So In such a case, the nurse that the patient has confided in you that he is smoking marijuana, you must be able to explain to the patient that because you didn't tell the doctor you were smoking marijuana, that is why you were giving this analgesic. And with this analgesic, if you are smoking marijuana, it will not help you much. Before this medication will be changed, I need to release the information to the doctor that you are smoking marijuana so that the analgesic will be changed. In fact, confide in me that I will release the information in such a way that the doctor will not come to ask you anything, nor he release the information to others who might not be in need of such information. And so you must seek for the patient consent after such essential information or sensitive information is released to you. If you want the patient to release information to you the next time, you must make sure that anything that the patient tells you, before you tell someone else, you must have obtained consent from that patient. Otherwise, the patient may not confide in you the next time to release such essential information. And so confidentiality is holding patients' information in confidence, i.e., treating patients' information as private. And so the patient that lives down your area, down your lane, who tested positive for HIV in your reproductive unit, such patient, you must not go telling your family members that the lady who lives down our lane tested positive for HIV. That will not be treating the patient's information confidential. Even gossiping about patient's information among health workers, when you know it's of no consequence, is inconsequential to the patient's health needs. In other words, you are not treating the patient's information confidential. As a palliative nurse, you must be veracious. And veracity means that you must always use the tool of truthfulness. You must always tell the patient the truth. A patient calls you with tears dripping down the cheeks, and then the patient tells you in a very sad tonation that, will I survive? In that moment, as a nurse, you must make sure that you manage your emotions and also show some empathy to the patient. So, in as much as you need to have some empathy, you must also balance between being empathy and also veracious. Knowing that this patient will not survive, you will not go out there chest out and tell the patient, no, you will die. You will not be showing empathy enough. And in as much as you shouldn't also tell the truth, or you should tell the truth, you must not also go there and tell the patient, this condition that you are having, definitely you are going to die. On the other hand, nor lie that even though you know that the patient will die, and tell the patient you will live. Oh, we are giving you medications, you'll be fine, don't worry. And then the patient dies. That will not be veracity. Veracity says that always you must tell the truth. So if a patient is going to die, or if you know the patient's condition is that the patient will not survive, and the patient calls you, will I survive? You must tell the patient wisdom. You must give the patient an answer that will not be answering whether yes or no you are going to die, but it will settle the patient some way, somehow. So, for example, you can say that health workers are doing their best. Family is doing their best. Everybody surrounding you is doing their possible best to ensure your recovery. But you know that the rest is in the hands of God, for example. Or the rest is in the hands of Allah. Or it's in the hands of whatever being that the person believes in. If you haven't served a medication, and you know patients who are usually having terminal illness, they don't want to take their medication because they are fed up. And so as a nurse, you walk to the patient, and the patient begs you that today, forgive me, I won't take the medication. Please, you just dump it and go and chat that you have given. It's fine. It's fine by me. Today, I will not take the medication. And then you also go and dump it and go and chat that the medication has been given. That is not veracity. Patient tells you that today I am eating, I know that the food that I'm eating, it will make my sugar rise. And then Dr. So and so will be on my neck if I eat this food. But I feel for it. Allow me to eat. Please don't document. And nurse too, you agree. And then allow the patient to eat a food that will rise the glucose level, and you don't document because the patient feels for the food. That will not be veracity. And so at all points in time, you must make sure that you use the tool of truthfulness. Non-malfeasance. Do no harm to the patient. That is what it means. Do no harm to the patient. And so non-malfeasance, you must make sure that all the time you will not do any harm to the patient. So, for example, a patient who is having chronic or severe head injury, or maybe a psychiatric patient, or even if the patient is not psychiatric, the patient is confused as a result of certain condition that the patient is having, and the patient gives you a dirty one, slap you, as a nurse or as a healthcare provider, you must make sure you do not return the slap. You must make sure you treat the patient as one who is confused and ill. Sometimes it is very, very difficult for you to suffer abuse from patient and stand aloof and do not react. But mind you, ethics are things that you are obliged to conform to. But morals are things that it is your wish. You can decide to be moral or not moral. But with ethics, you do not have any choice than to be ethical as a nurse. So you must not give IM medication on the inner upper quadrant of the gluteus muscle, but rather you are obliged to give at the upper outer quadrant of the gluteus muscle. And so if you do give a patient medication and afterwards the patient is paralyzed, you are not ethical. You have done harm to the patient. And you have done non-malfeasance. Beneficence. Everything you do must benefit the patient. That's the meaning. And so with beneficence, you must make sure all that you do benefits your patient. And so you must make sure you give the patient education about his condition or her condition. Tell the patient about the side effects of the condition or of the medication. You must make sure that you encourage family support for the patient. You must make sure that medications are given via or observing all the rights of medications. You must make sure that the patient do not develop, you change the patient position too hourly or timely so that the patient will not develop any pressure sores. As a healthcare provider, you must be justice. You must treat all persons equal, no matter their color, race, creed, or social status. you must not be working so hard in a ward because a member of parliament is in that ward. But the day that the ward is full of porters, or the day that the ward is full of ordinary Ghanaians who are also made up of blood, you tend to misbehave. Healthcare providers, you must be justice. Treat all persons equal, just as the nursing pledge says. You should not be treating your classmate better in a ward that you find yourself than the other inmates, because just for the mere fact that the person is a classmate, not even your mother. So the good care you give to your mother, you must make sure that you give the same care to each and every person on the ward. I'm sure anybody who is listening to me is asking, how possible? This is my mother we are talking about. But in fact, if you want to give good care to your mother, just because she is your mother and so she doesn't die, you must make sure that a nurse who is ethical, you transcend or you will translate same care to others who are also in the same ward so that they also don't die. Otherwise, you are not doing justice. You stand by this particular patient because this particular patient is your classmate. And then that particular day, you stood by the person for close to 3 hours. Meanwhile, the whole shift lasts for 6 hours. Other patients were calling. You hardly hear them because your classmate is on the ward. Even when your classmate doesn't need anything, you are seated by her and chatting with her when others are critically ill. That is not justice. As a nurse, you must make sure that you treat all persons, no matter their social status, equal. And autonomy, as I have already explained, you must respect the independence of your patient. Madam Equia is screaming on top of her voice because she is having end-stage kidney failure. The next woman, right by Madam Equia, is Auntie Abena, who is also having the same condition that Madam Equia is having. But Madam Abena or Auntie Abena is lying down quietly and not shouting. A nurse who is not being autonomous will say that, Madam Equia, why are you shouting all over? You have the same condition as Madam Auntie Abena or Auntie Abena. Why is Auntie Abena not shouting? But rather, you are shouting all over. Meanwhile, we have given you all your medications. Why are you disturbing the world like this? You, the nurse, you are not being autonomous. You are not using the ethical principle autonomy. Because Madam Equia is different from Auntie Abena. They are two different patients having two different conditions. And so you must treat each and every one independent of the other. You must not, just for the mere fact that they are having the same diagnosis, ever think that they will behave the same way. Because the transcultural theory even states that where people are coming from even determine their adaptation to a certain condition. Two children who are one coming from Choco, and the other, one born bred at Choco, the other born bred at East Legon. These two children are having cancer just for the mere fact that they are coming from two environments. You don't expect them to behave the same way. Sometimes it is possible that the guy from Choco will be so quiet and be cooperating with the pain, whilst the guy who is from East Legon, who is well pampered, will be screaming. You must treat them independent of the other. You do not bag 2 patients, 3 patients, and treat them equally because they are having same diagnosis. No matter the diagnosis, how similar they are, you must make sure that you treat them independently, and you must respect their independence. That is autonomy. You know, we will be talking about pain a lot in palliative care. But apart from pain, which is a symptom of some chronic illness, other chronic illnesses have been spelled out here in this slide. And so because we will be focusing on pain, we have listed other symptoms, and it's followed by an assignment. The other symptoms include seizures, fever, nausea, vomiting. These are other symptoms of other chronic illnesses. Nausea, vomiting, dizziness, chills, dyspnea, anorexia, incontinence, wounds, confusion, anxiety, insomnia, indigestion, hiccups, diarrhea, constipation, vaginal discharge, urinary difficulties, mobility problems, loss of weight, and the rest of them. Now the assignment. The assignment is name a chronic illness. Discuss the management of 8 other symptoms of the named illness. So you discuss the management of 8 other symptoms of the named illness. So aside pain, what other symptoms can you have or will you have in relation to the named chronic illness? And then you tell us how you manage each of the symptoms that you have listed. So that is the first assignment for palliative care. Right. Pain management. Pain management. As I already said, palliative care was found by Dame Cicely Saunders, and this is how he defined pain. The concept of pain, she defined the concept of pain as suffering that encompasses all of a person's physical, psychological, social, spiritual, and practical struggles. So, pain was defined by Dame Cicely Saunders as holistic. Holistic. Capturing all the dimensions of care, be it physical, psychological, social, spiritual, and other dimensions of care. The International Association for Study of Pain also defined pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. That is how the International Association for the Study of Pain defined pain. The widely used definition of pain, or the most spread or the most common definition of pain, is the one that was defined by McCaffrey, 1968. Pain was defined as whatever the experiencing person says it is, existing whenever the experiencing person says it does. So pain is whatever the experiencing person says it is, whenever the experiencing person says it does. That is pain. And so pain cannot be determined by the health worker. It is the person who is going through his pain that should tell you how intensive the pain is. That is why mostly, even when you are using the pain rating scale from 1 to 10, you must ask the patient, on a scale of 1 to 10, how will you rate your pain? 1 is mild, 2 is a little mild, 3 a little than the 2, 4 a little more than the 3, 5 a little more than the 4, like that. And so how would you rate your pain? Now the patient says it is 10 over 10. Even if I had my own way out, I would say it is 12 over 10. And then the healthcare provider said, oh, it's up to you. No. According to the definition of McCaffrey, it is whatever the experiencing person says it is, existing whenever the experiencing person says it does. And so, of course, whatever the person tells you the pain is, you must accept it. But sometimes, too, as healthcare providers, we use our discretion, because hysteria is also there. Some people just pretend to be in pain so that they will call for attention. And so as health workers too, you must also be vigilant so that you don't only follow what someone is saying and then give a strong analgesic. That is why, according to the World Health Organization ladder on analgesics, you always start from a mild analgesic before you graduate. You just don't go and start from a strong analgesic. Okay, just because a patient has said that the pain is 10 over 10. You still have to start from the P-mols and the roofings, so that if the person is still complaining of pain, you can upgrade it to a moderate one and then finally a strong analgesic. Now let's talk about the types of pain. We have a type of pain based on location. So classification of pain based on where it is in the body may be useful in determining the client's underlying problem or needs. Complicating the categorization of pain by location is the fact that some pains radiate, spread, or extend to other areas. So this is a form of pain, a pain by where it is located. Pain by its duration. And so under duration, we have acute and chronic. So whether the pain happens suddenly or the pain has been there for over a long period of time. So acute pain lasts through only through the expected recovery period, whether it has sudden or slow onset and regardless of the intensity. And then usually chronic pain lasts more than 6 months and over. The intensity of the pain. Just as I was using the pain rating scale, if a patient risks pain from 1 to 3, we say that the pain is mild. If the pain is rated from 4 to 6, we say it is moderate. 7 to 10 is severe. Now, etiology. So the cause of the pain. Physiological pain experienced when an intact, properly functioning nervous system sends signal that tissues are damaged, requiring attention and repair. So that is physiological. Physiological pain is when impulses are sent to the brain that tissues are damaged, and so a repair is initiated as a positive feedback mechanism. Somatic pain originates in the skin, muscles, bone, or connective tissue with sharp sensation of paper cut or aching of a sprained ankle. So this one, it usually stems from a body or an organ of the body. So it's either emanates from the skin or it emanates from a body part. This is not necessarily physiological, but it involves a body of the whole system. So maybe a prick, something pricks you, and then you feel the sensation, or something touches you, you feel that something has touched you. That is somatic. Visceral is poorly located and is usually may have cramping, throbbing, pressing, or aching quality, often associated with feeling sick. And so with a throbbing pain, it's usually emanates from the peripheral nervous system and not central. And so it is not well sensed than the pain that is emanating from the central nervous system. Now the concepts of pain. We are talking about some concepts of pain. We have pain threshold. Pain threshold is the least amount of stimuli that is needed for a person to feel pain. So the least amount of stimuli. So it is said that men have a lower pain threshold than women. So women have a higher pain threshold because, in other words, women can withstand pain more than men, because even their monthly experience of menstrual pain better adapt them and adjust them to pain than men. Okay, so men with the least pain, they feel pain, and so the least amount of pain that will make someone feel pain is called pain threshold. Okay, and then pain tolerance is the maximum amount of pain that a person will receive and then seek avoidance from the pain. The maximum amount of pain stimuli someone can experience. So when it comes to pain tolerance, women also have higher pain tolerance than men, because they are able to withstand higher amount of pain than what men will be able to withstand. Hyperalgesia. Hyperalgesia is unchangeable pain that is denotes heightened response. So someone who is hyperactive, just in the concept of hyperactive, someone who is hyperactive is someone who can't sit at one place. The person is all over. Okay, so when we talk about hyperalgesia is someone who is extra sensitive, hypersensitive to pain. With the least amount of pain, the person feels it. Okay, allodynia is a non-painful stimulus that induces pain. So, for example, you hear a bad news, and then you feel pain, even though physically you've not been hurt or you've not been injured physically, but you have heard something which is not pleasing to your heart, and so you feel pain. Someone can say, the thing that the person told me is so painful. That is allodynia. Dysesthesia is an unpleasant pain sensation when touched, and it emanates from the peripheral nerves. Now let's talk about physiology of pain. Physiology of pain. How pain is transmitted and perceived is a complex, in part because of the nature of the fully integrated, constantly changing structure of the central nervous system and the symphony of chemical mediators, only a fraction of which are understood. Nociception. The peripheral nervous system includes peripheral sensory neurons specialized to detect mechanical, thermal, or chemical conditions associated with potential tissue damage. The signals, when these nociceptors are activated, must be transmitted to spine, brain, and signals are modified before they are ultimately understood, felt. So we have 4 physiologic processes so far as nociception or pathology of pain is concerned. So the first process of pain is transduction. The second is transmission. The third is perception. And the fourth process of pain is modulation. So now let's talk about transduction. During this process, nauseous stimuli with potential to injure tissue trigger the release of biochemical mediators, prostaglandins, bradykinin, serotonin, histamine, substance P, that sensitize nociceptors. Nauseous or painful stimulation also causes movement of ions across cell membranes which excite nociceptors. And so in the transduction stage, nauseous stimuli, which is the pain, once the person is exposed to pain, certain biochemical mediators are secreted, okay, including prostaglandins, bradykinin, serotonin, histamine, that sensitize nociceptors. So nauseous or painful stimulation also causes movement of ions across cell membranes, which excite nociceptors. That is how the pain will move up to the brain. So the movement of ions across cell membrane, so the chemical mediators will excite one ion to cause a charge to the other, just like anions and cations attract each other. So when these ions are released, they move in a fashion such that if it is happening on a peripheral nerve, the movement of ions across cell membrane is the means by which the pain stimuli or the nauseous stimuli will get to the spinal cord, which is a central nervous system, and finally get to the brain for pain to be felt. For pain to be felt. And so when one is exposed to pain, there is secretion of biochemical mediators, which we have cited examples. And these biochemical mediators will cause movement of ions across cell membrane. And then finally, it gets to the brain for pain to be felt. So this stage of transduction basically is when someone is exposed to pain, the person gets biochemical mediators secreted, and then now ions move from one cell membrane to the other. That is transduction. Now let's move on. So this is a clinical application to transduction. Pain medication can work during this phase by blocking production of prostaglandins. So if you are able to identify the pain on time, and then you administer pain medication, the pain medication can block the prostaglandins from being secreted. And so once the prostaglandins are being blocked, ions will not move across cell membranes to reach the central nervous system for pain to be felt at all. Okay, so this one can reduce pain by blocking the production of chemical mediators such as prostaglandins. So the phase of transmission has three main segments. I mean, don't forget the phase of transmission is the second phase of pain physiology. We have spoken about transduction, and we have said that the transduction, that's the point where the person gets exposed to pain, and then chemical mediators are secreted, and now ions are moving across one cell membrane to the other. So the transmission phase is the continuation of where the transduction stopped. So as ions are moving from one cell membrane to the other, if the pain, mind you, the ions are not just moving by means of moving. It is transporting the pain from where the pain is happening to the central nervous system, which is the spinal cord, to the brain. Okay? So while the ions are moving and transmitting the pain, okay, the first segment of transmission is when the pain travels from where it happened, that is the peripheral nerves, and get to the spinal cord. That is the first stage of transmission. The second stage of transmission is from the spinal cord, and then it ascends via the spinothalamic tract to the brainstem and the thalamus. Okay, so when it travels from the spinal cord through the spinothalamic duct, which is the pain pathway of the spinal cord, it gets to the brain stem and then the thalamus. So you get to know what the brain stem and the thalamus does to the pain stimuli. Now the third segment, it involves the transmission of signals from the thalamus to the somatic sensory cortex where pain perception occurs. So pain transmission between the thalamus to the somatic sensory cortex. So from the thalamus, it moves to the somatic sensory cortex, and at the somatic sensory cortex, that is where pain is found, or that is when pain perception occurs. That is why we are saying that once pain happens at one point, there is secretion of chemical mediators. The chemical mediators will cause ions to be released and then move across cell membranes. And once that happens, transduction is done. When the pain moves across cell membranes to get to the spinal cord, that is the first stage of transmission. When it moves from the spinal cord through the spinothalamic duct to the brainstem and then the thalamus, that is the second stage of transmission. And then the third stage of transmission is when the pain moves from the thalamus to the somatic sensory cortex where pain perception occurs. And that will be the end also for transmission. Now that this is a clinical application, pain control can take place during this second process. Opioids block the release of neurotransmitters, particularly substance P, which stops the pain at the spinal cord level. And so an antagonist, which is an opioid, can go to block the pain stimuli from being transmitted. And so pain will not be felt when you give a painkiller at this particular point in time. Okay, so capsaicin may also deplete substance P that could inhibit transmission of pain signals. Now, under modulation, often described as descending system, occurs when neurons in the thalamus and the brainstem send signal down to the dorsal horn of the spine, the lower part of the spine. These descending fibers release substances such as endogenous opioids, serotonin, norepinephrine, which can inhibit ascending nauseous stimuli impulses in the dorsal horn. So this is a positive feedback mechanism. When the pain finally gets to the somatic sensory cortex, the body finds a way of reducing the pain. And the way of reducing the pain is that the somatic sensory cortex sends the pain that has reached itself back to the dorsal horn of the spine. And at the dorsal horn of the spine, the body secretes its own opioids called endogenous opioids. And as we all know, opioid reduces pain. Okay? So now you realize that when pain happens, or when you are hurt, sometimes you don't even take a painkiller, and then the pain goes down itself. That process happens. Okay? When the full perception of pain is achieved, now there's a positive feedback mechanism whereby the pain stimulus is sent down the dorsal horn of the spine, the descending down, or the descending parting of the spinal cord, and at that particular point, the endogenous opioids are released, and other serotonin or norepinephrine is also released, which goes to reduce the pain even when painkiller or analgesic hasn't been taken. So that is modulation. The system itself moderates or kind of reduces the full stimuli of the pain by secreting certain substances by the body that will reduce that. Now, perception. Perception It is when the client becomes conscious of the pain. Pain perception is the sum of complex activities in the central nervous system that may shape the character and intensity of pain perceived and the meaning ascribed to it. And so, finally, when the person becomes conscious of the pain, especially when it happens in the somatic sensory cortex, when the pain is finally felt, is perception, as we are talking about here, perception. So usually, we consider perception after modulation because usually the pain that is felt is not the actual pain that you were exposed to, because the pain that is felt finally will be a modulated pain, a pain that has been moderated. Because when the pain got to the somatic sensory cortex, where you had the perception of the pain, with time the pain diminishes because the pain was sent back to the dorsal horn of the spine so that endogenous opioids will be secreted to reduce the pain. And so you experience the heightened pain, and then finally a positive feedback mechanism is sent to the dorsal horn of the spine, which will bring the pain finally down. And all of those happen under modulation. And then finally, the final stage is perception, where the person becomes conscious of the pain. Of course, we have mentioned that the person becomes conscious of the pain under transmission, under the third phase. But I'm saying that that is a heightened pain. That is when the pain stimulus gets to the brain freshly. Okay? So immediately it gets to the somatic sensory cortex. Of course, the person will feel the pain. But it undergoes moderation, under modulation, where positive feedback mechanism is sent, and then endogenous opioids are also secreted to reduce the pain. Okay? Then comes the perception of the pain, whereby the person experiences the heightened one, and now the person experiences the reduction of the pain, even when an analgesic hasn't been taken. Response to pain. The body's response to pain has both physiologic, psychological aspects. The sympathetic nervous system response, resulting in fight or flight response with noticeable increase in pulse and blood pressure. The person may hold his breath or have short, shallow breathing. So response to pain always goes with the sympathetic nervous system, resulting in the fight or flight, secretion of adrenaline, whereby the person's blood pressure goes up, the person seizes breath because the person is in pain, and then also there is shallow breathing because of the adrenaline that has been secreted into the blood. The person starts panting, right? Factors affecting pain: ethnic and cultural values. So where the person is coming from. If you take our brothers and sisters coming from some part of the northern region, their response to pain is different. Even as a woman, your womanhood is not complete if you are unable to give birth home. So if you are a woman and then you are in labor and you go to give birth in the hospital, you are seen as a weak woman or unhealthy. A woman is one who is able to withstand labor pain and give birth home if you go to some parts of the north. So their definition of pain is different. Even when someone dies, you only hear them make sounds and not cry. Okay? So if you cry, you are seen as weak. So if someone who is coming from such ethnic or cultural background come to meet someone in the south, and then you consider the two to be the same, you are making a big mistake. Because their ethnic and cultural differences is accounting to how they react to pain. Okay? If you compare man and woman, their response to pain is different. If you compare how a rich man will respond to pain and then how a poor man will respond to pain, they are different. Ordinarily, a poor man will have a better tolerance for pain than a rich man, ordinarily. okay, or where the person is coming from, okay, maybe the person is one who has been having pains, or even because of the work that the person does, the person has been exposed to pain for a long period of time, so the person has become somehow used to some pain or some intensity or level of pain. Okay, so someone's way of life or someone's upbringing determine how pain affects the person. Developmental stage, you don't expect children to respond to pain the same way adults will. Even children, when you give them injection, they start crying. You don't expect a full-grown man to cry when he is giving an injection. Even though the person will feel some discomfort, but the person will not cry. Okay, so children have a different way of responding to pain as compared to adults. So developmental stage to affect pain. Environment and support people. Environment and support people. So people who have support have a better response to pain than people who don't have support. Pain really gets to them. So if two patients are living on the ward and one has family members around caressing the person and going through the pain with the person, always in support of the person, whenever the person is going through pain, they also go through same pain. They try to put the person to rest, try to ensure comfort as much as possible, as compared to someone who doesn't have anyone. The person bears his or her pain all alone. Okay? So if there are support persons in the environment and also the environment is conducive, the person is able to withstand pain better than someone who doesn't have any support people. Past experience of pain also affect pain, because a mother, a multiparous woman, a woman who has delivered before, has a better idea than a nulliparous woman. So a woman who has never delivered, and the pregnancy the person is carrying is the first pregnancy. This person even though has heard about how labor pains is, the person has never gone through. And so this person is likely to behave in a certain manner when labor pain starts than the multiparous woman who has delivered before and so is aware of labor pains. Okay, so your past experience of pain also puts you in a better position to withstand pain, and so past experience also affects pain. Meaning of pain, how people, or the meaning people put to pain. So for example, if, as I cited earlier, giving birth in the home is seen as someone who is strong and can withstand pain, and going to give birth in the hospital means that you are weak and you are unhealthy. Okay, the meaning that people are ascribing to pain, even though wrong, it tells you that no matter how successful you are when you go to deliver in the hospital, they see you as a failure because you couldn't deliver in the home. So with the meaning of pain, even when the person feels that this pain is very severe, but just for the mere fact that the person who don't want to show the pain, or don't want to show the pain to suggest that he or she is weak, the person will see the pain as mild, or the person will not react for anybody to know that he or she is in pain. And so the person gives a different meaning to the pain altogether because of certain conception the person is having. And with the meaning of pain too, it can also mean that the person doesn't really want to accept that he is in pain, or the least pain that the person is having, the person feels that the pain is so unbearable. It is either the person is exposed to severe pain and see it as a mild pain, or the person is experiencing a mild pain, but the person sees this as so severe. And so the person is redefining what pain is per his or her own experience. Nursing management includes assessment and diagnosis. With assessment, you need to collect the patient's history, location of the pain, pain intensity, with pain scale, parting, precipitating factors, alleviating factors, associated symptoms, effect on daily activities, coping resources, effective response. Under assessment, that is when we usually refer to as PQRST. Okay, so the P is what precipitates the pain. Q is quality of the pain, that is the intensity. R is radiation, where the pain radiates to. Maybe you have the pain at your ankle, but it radiates to your groin. And then we have the severity of the pain, which is the S. And then we have the time, whether it is acute or chronic. So you need to assess the pain using the PQRST. Okay. And then finally, it is diagnosing of the pain. Barriers to pain. Barriers to pain. What will make someone not show that he or she is in pain? Right. So attitude of nurses or knowledge deficits. Maybe the patient doesn't know much about the condition, and so the patient doesn't really know whether to complain about the pain or not to complain about the pain. Or maybe the attitude of the nurses. The nurses are shouting on the patients all over, and so even when the patient is in pain, the patient pretends as if he is not or she is not. And so attitude of nurses can be a barrier to pain, especially when nurses are being hostile to clients or patients. And also, if patient doesn't know whether to inform nurses about pain, or not to inform them about the pain, or to inform relatives about pain, that one too, it can be a barrier to pain. Clients may not report pain because they expect nothing can be done. Clients may not report pain because they expect nothing can be done, especially when they have done previous complaints about pain and nothing was done. Now, they don't complain about it anymore because they feel nothing will be done about their pain. And so that one too can be a barrier to pain, or is a barrier to pain. Failure of becoming addicted, especially if long-term opioids use is prescribed. So the fear of becoming addicted can also make you not talk about your pain, and for that matter, it becomes a barrier. Pseudo-addiction results from under-treatment of pain, where clients will become focused on obtaining medication. Right, and so this one is when patients are receiving certain medications or obtaining over-the-counter medications for pain. Meanwhile, they are not taking the appropriate dose for the pain, or they are not even taking the correct medication for the pain. And so it tends to reduce the pain some way, somehow, but the pain will still be there. The pain will still be there. So they obtain over-the-counter medications to treat their pain, even though the dose that they are taking are wrong. It can also be that the medication that they might be taking is wrong, but some way, somehow, it reduces the pain, even though the pain still persists. And so that one too can be a barrier to pain because they may not complain to the healthcare provider because they are taking some medication that they have bought on their own. It is usually, most of the times, these analgesics are topical. After you have given all your medication, when they are coming to sleep, they apply some on their body. Some even use rub. But when you are lucky for someone to use rub, that one immediately the person uses, the scent alone is enough for you to sense that someone is using rub. And so you walk to that particular bed and ask the person why he or she is using the rub. And when the person complains of pain, then you'll be able to find out But if the person is using a cream that doesn't have a strong smell, whenever the person is coming to sleep, for example, the person applies some on the knee and sleep, and because of that, the person is not complaining of the pain. That one too is a barrier. Pharmacologic management of pain. We have mild pain analgesics, or we have mild pain killer, which is analgesic. It includes paracetamol and NSAIDs. Then we have mild to moderate painkillers, which include NSAIDs, paracetamol, weak opioids like hydrocodone, and the rest of them. We also have moderate to severe, where we can get pethidine in there, and morphine. Also as example, morphine, fentanyl, oxycodone, pethidine, pentazocine, and we also have amitriptyline, all of them as part of moderate to severe. So we have non-steroidal anti-inflammatory drugs that are drugs that reduces inflammation, and in other words reduces pain, because swelling, which is a cardinal sign of inflammation, causes pain, which is also a cardinal sign of inflammation. So if someone is giving a non-steroidal anti-inflammatory drug, the non-steroidal anti-inflammatory drug will go to reduce the swelling that the person is having, and also will go to reduce inflammation or the process of inflammation, so that the person can have a relief of pain. Antidepressant and anti-epileptic drugs are also given, and it acts as primarily within the pain pathway of the central nervous system through peripheral mechanisms. Cannabis are also used in treating severe pains or chronic pains, and it's usually for gotten from marijuana and the rest of them. Let's talk about non-pharmacological management. Non-pharmacological means that it is not by means of drugs, but it is by nursing management, for example, bed rest. So when you restrict movement, perform nursing procedures together, and then also you restrict noise on the environment, you improve ventilation, you give comfortable bed free from creases and cramps, that will all inure to the rest and sleep of the patient. Manipulation and mobilization, for example, in the case of dislocation, the patient will be given an analgesic where the pain will be reduced, and then the dislocation will be manipulated, and then the displaced bone that has gone out of the original anatomical position will be brought back in a position to the normal anatomical position. So same will be done in fracture dislocations and all of that. Traction, also we have skin traction, we have external fixators and all of that. So with the traction, it basically a skin traction that the leg is brought in a position, and then it is bandaged, and then it comes with a rope. The skin traction, for example, comes with a rope whereby a load will be hung on the rope so that it will stretch or pull the fractured bones together, and then cause the bones to be in a proper alignment for healing to proceed. Then we have therapeutic modalities, and the therapeutic modalities should be considered an adjunct to an active treatment program in management of acute low back and the rest of them. We have transcutaneous electrical nerve stimulation, which is also used in the treatment of epilepsy. Superficial heat, which is a topical application for people who are in joint pains, arthritis, back aches, neck pains. They apply to those parts to reduce the pain. And also we have cryotherapy, the use of ice or ice packs to manage pain. So if someone is having a pain, and then a cold compress is applied on it to reduce the pain. exercise, which improves blood supply to a part of the body which is in pain, also can reduce pain or reduces pain. We have electrical stimulation as the last one, whereby high voltage pulse passes through the body to cause muscle spasms and then a subsequent gain of muscle strength, which can also improve blood supply to a body part. Now let's talk about grief, bereavement, dying and death. Grief, bereavement, dying and death. What is loss? Mind you, we have said that palliative care is the care you give to the critically ill patient, and it doesn't target at cure, and death is not surprising. And so once you are taking care of palliative patient, death is one of the things that we need to avert our attention to. So what is a loss? Loss is defined as experiencing of parting with an object, person, or a relationship that one values. Grief is psychological and physiologic responses a person experiences after the loss of a significant person. So grief is the trauma someone goes through after a loss. That is a grief. Or the physiological and psychological responses a person experiences after the loss of a significant person. That is grief. Bereavement is a state of desolation, state of unhappiness that occurs as a result of a loss. That is bereavement. And then mourning encompasses the socially prescribed behaviors after the death of a significant one. And so mourning usually is defined by social context. So if you are mourning someone in an area whereby you don't cry, but you only make sounds, you have to make sound. If you are coming from my hometown, whereby even when the family members are not crying well, crying can be given out for contracts, for people to come and cry at a funeral. And then, if you are a woman and then your husband is dead, and then you are not crying enough, you don't take care, people will start pinpointing you as the cause of the death. And so if you are coming from the part of Ghana where I come from, crying is the order of the day after a death. And so the socially prescribed behavior after death of a significant one is crying. But other people too, it is maybe making noise or not eating or not cooking in that particular house for days, 40 days, and the rest of them. So now let's talk about the stages of grief. The stages of grief was brought up by Elizabeth Kubler-Ross in 1969. And she said that the first stage of grief is denial. So when someone loses a significant one, the person's first response is that of denial. The person don't seem to accept that that particular story is true. Now the person tends to be angry. So now the person displaces his or her anger on healthcare providers, especially when the healthcare providers were not cooperative enough or were not supportive enough in giving care to the patient. Now bargaining. Now the person starts bargaining with the supreme being or any being that he believes in for a second chance. Okay, so once the person starts doing that, you get to know that, okay, now the person has gotten into bargaining, and now the person becomes sad because the person is trying to now accept reality. So the person becomes depressed. And the person doesn't want to talk to anybody, mood swings and the rest of them. And now finally the person tends to accept. So DABDA, D-A-B-D-A, is denial, anger, bargaining, depression, and acceptance. Let's talk about dying. What is dying? Dying is ceasing to live, approaching death. Dying is ceasing to live or approaching death. Signs of approaching death. Signs of approaching death. And the signs of approaching death, we have categorized them under the various systems: respiratory system, circulatory system, central nervous system, gastrointestinal, and then genitourinary. And then we have taken them one after the other. Someone who is dying, the person's respiratory system becomes irregular, rapid, and shallow. The person's respiratory system becomes rapid, irregular, and shallow. That is the respiratory distress. Now, the person's circulatory system, radial pulse gradually falls, so you will not be able to feel the radial pulse. Once it stops, the apical pulse may continue for some time and it will also stop. Usually, pulsations are seen even after the patient has stopped breathing. Central nervous system. Reflexes and pain are gradually lost. So, under the central nervous system, too, the person starts losing reflexes. Pain may be, patient may be restless due to lack of oxygen to the brain. So, the patient may also be restless. Genitourinary, retention of urine may occur. Distension of the bladder as a result of the retention of the urine, and also forceful opening of the urethral sphincter, which will cause incontinence. Gastrointestinal system, the patient feels inability to swallow, and then incontinence of stool. So a person who is dying has reduced or a weak swallowing reflex. And the person also experiences incontinence of stool. Care of the critically ill patient. We have nursing care related to breathing, which we will talk about. We will have nursing care related to eating, nursing care related to elimination, nursing care related to immobility, nursing care related to cleanliness and grooming. So under nursing care related to breathing, we have administration of oxygen, elevate head and shoulder to enhance breathing, keep room ventilated and avoid overcrowding to allow for oxygen to circulate and proper air to circulate, and also periodic suctioning is necessary so that the fluids will not enter the airway to go and block the airway. Now, nursing care related to eating. The patient is unable to swallow even sips of water. IV fluids may be required. Give sips of water on teaspoon if patient cannot tolerate oral fluids to keep mouth moist. Maintain oral hygiene. So you need to also maintain oral hygiene. Now, nursing care related to elimination. Nursing care related to elimination. Constipation, retention of urine and incontinence of urine, and stool may be present. Catheterization has to be done. Perineal care to be cared for. So the person will have to be in catheter. Someone who is dying cannot be going to the washroom to urinate because the person doesn't even have full consciousness. So a catheter has to be inserted. The person's constipation, urinary retention must all be catered for. Nursing care related to immobility. Frequent skin care should be given, especially the pressure areas. So the person's pressure areas must be cared for. Patients should be comfortably positioned and position frequently changed. Nursing care related to cleanliness and grooming. Cleanliness and appearance are important until the end. And so cleanliness of the skin, hair, mouth, clothes has to be maintained accordingly. Right, so let's talk about death. We just finished with dying. So let's talk about death. Permanent cessation of all vital functions is what we call death. So signs of clinical death. What the doctor will see before confirmed death. No palpable pulses, be it the radial pulse or the apical pulse or the carotid pulse. None of them is felt. No heart sounds on auscultation. So the doctor used the stethoscope to auscultate or to listen to the heart sounds, and then there is none. No observed respiratory effort. There is no cardiopulmonary activity. There is no upward and downward movement of the chest. No breath sounds on auscultation. Pupils dilated and not reactive to light. So the pupils, when you irritate or sensitize it with light, it doesn't react. So all of these shows that the person is dead. No response to painful stimuli. You apply pain to the person doesn't respond. Absence of cornea reflex. And so the cornea doesn't respond, especially even when you prick it with a cotton. Cloudiness of the cornea. We will look at it in the diagram, how a cloudy cornea looks like. Rigor mortis. The person starts becoming rigid. If you don't straighten the extremities, the person starts becoming rigid like that. That is why when death is confirmed, the person's extremities will have to be straightened, and then you bring the person into proper position, and then you straighten legs, straighten hands, straighten neck, and put the person in a supine position, flat on the back, so that rigor mortis, even when it's setting, the person will not be crooked. Decreased temperature. There is also decreased temperature because the temperature controlling center is gone. The blood has also lost heat, and so the body itself also loses heat with time. Now that is how a cloudy cornea looks like. Right, so the one on your left, the eye on your left, is the one who is alive. And then the one on your right is the one who is dead. And so that is the difference between a cloudy eye and an uncloudy eye, or someone who is deaf, who is dead cornea, from someone who is not dead cornea. So care of the body after death. Before we talk about care of the body after death, I would want us to know how to break news of death to family. How to break news of death to a family. So in breaking news of death to a family, you first have to call the family members and offer them seats in the nurse's station or at the nurse's station. And once you do that, most of the times they get the impression that something is happening. Okay, so even before you start talking, you have to do some psychological preparation by asking them their faith. So you ask them, I hope you are Christians, or I hope you are Muslims, or you are hope, then you mention the person's religion. And now you know that death is a natural phenomenon, or the death comes from God. Okay, so whenever we are done with what we came to do on this earth, death happen or can happen to anybody. Okay, and so once you sit them down, you ask them of their faith, and then based on their faith, you start talking about death. And some of them will start crying, and you need to calm them down. Okay, you need to calm them down, but allow them to cry, but not to shout. And then you explain the circumstances surrounding the death, the fact that the person came in, what you did till the person died. You explain all of them to them, and then you give them the option whether they would want to see the body or will not want to see the body. Most of the times they would want to see the body, and so you will have to care for the body first before you will allow them to see the body. Okay, so before you even break news of death to the family, you must have cared for the body so that when they put in a request to go and see the body, you only walk them there for them to have a look at the body before you will notify the entrance lodge to call the main mortuary to come for the body. Okay, so care of the body after death. Actions of the nurse after death. After the physician declares patient dead, document in the report if patient had any valuable, they are handled to their relatives. So immediately death is confirmed or is declared by the physician, you need to document in the report book, and then you hand over any valuable to relatives. So these are the articles required for preparing the body. Bandage, soft cotton. The bandage is for ensuring or securing a wound that is bleeding. Cotton is for packing the nose and other orifices. Perineal part is for the vulva. And then sheet, you need to change the person's sheet if it is soiled. Restraint for jaw, you need to close the person's mouth so that house flies will not enter or other fluid will not exit, which will be very, very important in autopsy. You need to also restrain the hands and legs. You need a pair of gloves because you can't work with your bare hands. Thumb forceps. You need patient's own set of cloth, because that particular cloth will not come back to the ward again because it's going to the mortuary. That is why you need the patient's own set of cloth. Procedure. Now you wash your hand and put on the glove. Soon after the death is declared, remove pillow because you want to straighten the neck. If you don't remove the pillow for a period of time, by the time you remove the pillow, the person's head will still be like this. It will still be assuming the posture that it was assuming when he was lying on the pillow. So immediately death is confirmed, you need to remove the pillow. Gently put the patient in supine position. Supine position, that is, like you allow the person to lay on the back. Positioning is important after death because of rigor mortis. Gently close the patient's eyes and mouth. And the mouth, if you close and then there is still space, you need to pack with cotton so that houseflies and other insects will not enter the body. Remove all tubes and other devices from the patient's body, including cannula, urethral catheter, and other tubes, engine tubes are all removed. Nasal prongs or face masks that was being used to administer oxygen are all removed. Replace soil dressing with clean ones. Apply perineal pads and plug the rectum with cotton balls. Close the body from side to side and head to foot with sheets. Body should be labeled for identification label. So you have to fill the identification band and then put it on the patient's hand and also the leg. So patient is covered from head to toe and sent to the mini morgue. So explain protocol of death to family and ensure their compliance. One copy of death certificate should be with the hospital. So when you push the patient to the mini morgue, what you do is that you notify the security men who will call the main mortuary to come for the body. And when they come for the body, you need to hand over the folder to the patient so that they will send the patient's folder to the morgue. And then the morgue will also issue a death certificate to the patient, where one will be kept on the ward and the patient will go with one, while the folder remains at the mortuary. Identification tag. Patient's name, age. So on the identification tag, these are some of the information that you need to put on the identification tag. Patient's name, age, registration number, relative's name, maybe a next of kin, address, ward number, bed number, date and time of death, cause of death, date and time of admission. Right. So this is where we end today's lesson. Thank you for your audience.